It's a great pleasure to be here in Glasgow, and like James, I'd like to thank Giles and Sasha and Richard for the invitation to speak and for doing such a terrific job on the organization. I haven't been back in Glasgow since the ISMRM that Matthias Stuber alluded to, but it is a wonderful city, and every time I come here, I enjoy it thoroughly. So my task is to talk about Ferumoxytol enhanced MRA, and people have alluded to earlier on some of the relevance of Ferumoxytol. Here are my disclosures. So why Ferumoxytol? Well, again, I'm going to speak obviously mainly about our experience, but we're not the only group who have been using this agent. Generally, you know, it can be used where there are contraindications to the gadolinium-based agents, or where there are concerns about the gadolinium-based agents. And this is, of course, a very topical area, which I don't want to dwell on too much. But what I would emphasize mainly are specific strengths of Ferumoxytol, not necessarily reasons not to use other agents, but reasons why we would want to make a conscious decision to use Ferumoxytol. Well, what is it? It's an ultra-small supraparamagnetic iron oxide particle, or a USPIO, and it has a high T1 and T2 relaxivities, actually very high. The T1 relaxivity is comparable to Ablavar, which is no longer on the market, and that's another significant factor tending to consider because of the lack of an intravascular alternative, basically. But it's also got a very potent T2 relaxivity. And importantly, it has a very long intravascular half-life, at least 14 hours. That means once it's in for all practical purposes, and it stays in the blood pool. It's got a dextran derivative coat that envelops an iron particle core, and the mean diameter is about 30 nanometers. And it is taken up by the macrophage of the reticular endothelial system of the liver, spleen, and bone marrow, and incorporated into the body iron stores. So in the US, which really is about the only place that Ferumoxytol is marketed currently, it's licensed exclusively for therapy, for treatment of iron deficiency, until recently in chronic kidney disease only, and recently the indication has been expanded to iron deficiency in patients who are intolerant of oral iron. So here's a summary of its sort of pharmacokinetics. There are several, if you like, windows. It could in principle be used in the first pass phase to, for example, get information on perfusion. And then during this sort of long steady state phase where you can just image it at your leisure. And then eventually, over several days, it's incorporated into the iron stores. So this agent, by the way, is not approved by the US FDA for imaging, and its diagnostic use is off-label. And the FDA has issued a warning about potential hypersensitivity reactions and advised against bolus injection in 2015. So this is something to be aware of. We've had no issues, no safety issues with the use of the agent to date. And here's sort of a summary of some of the history of the use of Ferumoxytol for vascular imaging. It was actually developed originally as an intravascular MRI agent. And one of the first publications, in fact, was from Martin Prince and his group back in 1997. And then it sort of it went away, basically, for quite a while. And then it was published by Bob Edelman's group in about 2005. And then it regained popularity when we had issues with NSF in renal failure. I'm just off the plane and my throat is a little dry. Anyway, to summarize what our common indications are for the use of ferumoxytol. For venography, it's a phenomenal agent because once it's in the blood pool, it stays there. And it enhances everything. If something is patent, it enhances. So that can be used for mapping venous access, central venous occlusion, prior to venous intervention, and also in the portal and hepatic venous system. For arteriography in several indications, renal transplant patients, peripheral arterial disease, aneurysms, dissections, occlusions, and again, prior to and following intervention. It also has applications in cardiac imaging. We've used it quite a lot, as have other groups, in congenital heart disease. And I'll show you a couple of examples how it's useful in patients with cardiac devices like ICDs or pacemakers. Also, interestingly, we have found it very useful in patients who are claustrophobic because, a little paradoxically, although this agent sort of distributes and is very stable in the blood pool, that can be used to great effect to speed up not just image acquisition, but the length of a study, such that you can complete a whole body vascular imaging study in as little as 6 or 7 minutes table time. And that's faster than CT if you do the arithmetic. Okay, here's one example just to show the kinetics of the agent. This is a 3-day-old neonate child. This was a first pass image where we're just looking at the arterial phase at what we label time t0. And then this is at 1 minute and 40 seconds. Here we've basically imaged all of the arterial and venous system. And here's at 45 minutes, where things look pretty much the same as they did at 2 minutes. So again, once we get to the steady state, things don't change much. And that makes, this is unique with this agent. So here's an example. This is a 4-year-old child who had venous thrombosis. And again, these are just different reconstruction formats. Here's a conventional MIP showing occlusion of the common iliac vein. And again, these are volume-rendered reconstructions with specific coloring for the arteries and the veins. This again is something that can be done much more easily with ferumoxytol than other agents because it's practical. Okay, here's a patient with central venous occlusion, 56-year-old male with end-stage renal failure, and the study was done to look for venous access. And as you can see, there isn't much. Here's a MIP image on the left showing complete thrombotic occlusion of the IVC and the SVC. But we can see all of these collaterals. I don't think there's another way to do this. And here again, a very dilated azygous vein. And using this study, it was possible for our interventionists to find access through a hepatic vein and get a central line in actually fairly quickly. Here's another patient, 47-year-old male, post-renal transplant and right leg swelling. Not surprisingly, this is all thrombus in the IVC and extending into the transplant kidney. This is the original summary of the findings. And then after intervention, this is about a day after intervention, things look much, much better. Not normal, but heading in the right direction. And again, in principle, what one could do is you can do this study, inject ferumoxytol, do your pre-procedural imaging, do your therapy, and you could take the patient back and repeat the study without injecting any more Ferumoxytol and see exactly how things went. Here's another patient with end-stage renal failure and worsening varicosities. And again, we've got occlusion of most of the veins in the neck and chest and the SVC. This is a filter in the IVC. And again, here we have sort of dramatic display of all of these collateral vessels everywhere. And this is a pretty expensive and time-consuming way to image varicosities in the legs. There again, this is basically is done in 2 breath holes. You can image every blood vessel from the neck to the thighs, and then do high-resolution imaging of the vessels from the thighs to the calves. The whole acquisition, again, is done in a few minutes. The post-processing, however, takes longer. Here's an application for machine learning, which I hope will take off quickly. Okay, and what about Tavor planning? This is an application that we and other groups have found actually very, very useful. And it's important to define the access vessels prior to transcatheter aortic valve replacement. And again, with Ferumoxytol, we can image every artery, every vein in the body in a couple of breath holes. And the signal is such that really we get very, very good signal to noise, and these are very good for accessing, mapping access vessels. And this is extracted from a paper by Len Wen in Radiology earlier this year. And here are a few examples from that. Again, arterial phase, MIP recon. And what we've done here is we've overlaid calcification from a non-contrast CT on the Ferumoxytol enhanced MRA, such that we get everything, because it's important also to define the calcium burden, as you know, prior to Tavor, because this is of relevance for sizing the device. And we can do this really very easily. So in this whole study, there's no X-ray contrast and no gadolinium. Again, here's a different patient. Prior to Tavor, we image all the arterial lumen and the venous system. And here we have the same thing, but overlaying all the calcium from non-contrast CT. Again, all of the luminal anatomy is provided from the Ferumoxytol study. Okay, what about aneurysms for surgery planning? Here we see the complementarity of T1-weighted imaging and T2-weighted imaging post-Ferumoxytol. Blood becomes very reliably dark on T2-weighted imaging once Ferumoxytol is on board because of its T2 effect. So here, if we see signal, we know that this is not slow flow. This, in fact, is thrombus here. And this is the bright blood MRA corresponding to that. And here again is our volume rendered reconstruction. And here we can measure the dimensions of the aneurysm very accurately and see the perfused lumen and the thrombus. And the perfused lumen on the T2 is uniformly dark. So here we got T2-weighted imaging, T1-weighted imaging producing very reliable bright blood and black blood effects. This is the same patient now with the calcification, again from non-contrast CT, overlaid on the wall, and the thrombus we can see there between the calcium and the lumen. Here's another patient with a very complex thoracoabdominal aortic aneurysm, which we see here, and his renal failure. And here again, same story. Here we can see the entire very, very dilated, irregular aortic lumen. And I would propose that it would be maybe impossible to opacify this aorta as well as this any other way, even with CT. Because you can imagine this is going to be this is an 83-year-old lady, this is going to be a very slowly filling aorta. When do you time your bolus? And how big a bolus do you give? No problem with Ferumoxytol, every crevice fills, and then you just image it in a breath hold. And here again is the same patient with non-contrast CT, overlaying calcium, and there's the aneurysm and the thrombus. Another patient with severe calcification, which we'll see, but lots of vascular problems. And again, all of this calcification, which would actually make CT difficult, even with modern CTA, with all that calcium blooming. Okay, here's a patient with a complex dissection. Again, these colors are a bit dramatic. The false lumen is green, and the true lumen is red. But again, it's possible to basically to map these separately. And here again is the complex 3D anatomy. And again, this can be very difficult to time properly. This is all post-contrast. And again, this whole study, whoops, that was cool. I didn't know I had that sort of power. This whole study was done in 2 breath holds. Another interesting feature about Ferumoxytol is Cine imaging is really simplified. On the top here, we have our typical SSFP, which is a wonderful technique, but is prone to some artifact. So we'll see off-resonance artifacts up here in this post-dissection patient. Here are the same cines. This is a flash or a spoiled gradient echo cine, completely immune to off-resonance artifacts, post-Ferumoxytol. And the detail is really, it's impressive. And here's another case, a patient with an ICD. Again, this is our actually post-gadolinium Cine imaging, which is not too bad, but we still have a lot of saturation here within the cardiac chambers. And post-Ferumoxytol, things just brighten up independently of blood flow. And here's another patient with extensive scar in the myocardium. And again, this is somebody with an ICD, where we can't really use SSFP Cine to any effect because the ICD box ruins the field, but we get perfect Cine images post-Ferumoxytol. So, well, when is first-pass imaging helpful? And we do most of our studies, in steady state after slow intravenous infusion. Occasionally, it may be appropriate clinically to do a small controlled infusion, as Giles sometimes calls this. And this is also a technique that has been used, I think, fairly extensively by Giles and his colleague here in Glasgow. And this is a twist sequence with just 1.5 mLs of Ferumoxytol. And this is 45 milligrams of iron, which is kind of homeopathic. A different patient. Again, that's just one frame from a time-resolved study after 1.5 mLs. And here's a patient who had neurological symptoms and renal failure. Again, we see basically perfectly wide open carotids and vertebrovascular system. Okay, I'll finish up talking briefly about pediatric congenital heart disease. The 2 images on the left are 4D music images. And this is a technique developed by our group at UCLA. This has sort of completely changed the way we image our pediatric patients now. But also, it's possible to do very good 4D flow imaging with ferumoxytol and boost the signal to noise. So this is a patient with an ASD, and here we can see the left to right flow very nicely shown there. And for neonates, this is a tiny baby who was thought to have a diaphragmatic hernia on echo. Doesn't. This is a huge sequestrated lung with a really enormous feeding artery here on the 4D music. And again, we can see on 4D flow the systemic supply to that right lung. Again, that completely changed the management. But this is other anatomy in this same patient. More complications in here than we could talk about in a half hour, but they're all there. Everything that we need to see, we can see in one acquisition. And this is a 2-day-old. We imaged a few months back. Very, very weird aorta. Unfortunately, this poor baby went into left ventricular failure. You can see there's poorly functional dilated left ventricle, and he died within a few weeks of this and had an autopsy which showed absolutely perfectly correlated with the MRI study. But this is a very weird descending aorta. There's an interrupted arch, and again, more detail than we have time to discuss. But again, it's a comprehensive study that's really supported by ferumoxytol. Without that, we couldn't get this sort of detail. And this technique has been also used in other centers, including Children's Hospital in Philadelphia and Lurie Children's in Chicago. Here are some cases from both of those institutions where it's being used to great effect. So in conclusion, ferumoxytol has produced reliable, high-quality angiographic studies across a wide spectrum of age and clinical applications. Safety and efficacy data to date point towards a high benefit to risk ratio in appropriate patient groups, but more work has to be done on this. And that's about it. I'd like to acknowledge my colleagues and collaborators, and thank you for your attention.